Cerebrovascular accident, CVA, or stroke is defined as the sudden onset of neurologic signs and symptoms resulting from a disturbance of blood supply to the brain, leading to temporary or permanent loss of function. And it's the most common and disabling neurologic condition affecting adults in the United States. We've got a couple videos in this lecture. I'm not sure if I'm going to get them to play in the recording or not, so we will try. But if they don't, please go back through in the PowerPoint that you have access to and get them to play. It will not play, so you will have to do that on your own. So etiology of strokes, we've got two different types that we're looking at primarily, and then transient ischemic attacks are their own separate thing. So if we're looking at ischemic CVAs, these are more common. They are caused by a thrombus or an embolus where blood flow is obscured to an area of the brain. It forms an ischemic penumbra around the infarct. So not only do we have tissue death where the area of infarct is, but then that extends out from the area of infarct. Our hemorrhagic CVAs are less common but are more fatal, and they are caused by vessel malformation, vessel changes due to hypertension and aging, trauma, exposure to toxins, impaired coagulation, or some type of lesion. And so this is basically where the brain bleeds out. And then transient ischemic attacks are not a CVA. They are something that passes. They only last a short amount of time, hence transient. But they are due to a decrease of blood supply to an area of the brain. And this can often be something that gives us an indication that there is an obstruction to that blood flow and that it can be a precursor to a stroke. Transient ischemic attacks involve loss of motor, sensory, or speech function that resolve within 24 hours. And so that resolution within 24 hours is the key component to a TIA. 40% of individuals who have a TIA will sustain a stroke. Let's see if this one will play.
You've probably heard of people having a stroke, and you're probably familiar with the notion that it has something to do with the brain, and you'd be right. In particular, it's a rapid loss of brain function because of something strange happening with the blood flow to the brain. And let me show you that in a little bit more detail. And to do that, let's think about the two major types of stroke. There's the ischemic strokes. There are the ischemic strokes, ischemic stroke, and the other type of stroke is hemorrhagic. And these can also be kind of subcategorized, but I won't go into all of the details there. Hemorrhagic stroke. And if I really just define ischemia and hemorrhaging to you, I think you'll have an idea of how these strokes are different and how they interrupt the blood flow to different parts of the brain. You know from the videos on stenosis and ischemia and the videos on heart attacks that ischemia is a lack of blood flow to certain body tissues. So an ischemic stroke is actually very, very similar to what we saw in a heart attack, except it's not occurring in a coronary blood vessel. It's occurring in a blood vessel in the brain. So let me draw that right over here. Let's say that this is a blood vessel in the brain. This right here is a blood vessel in the brain. And let's say the blood is flowing in that direction. This is an artery. And so you can imagine that maybe there is a blood clot that forms in some part of the brain. Let me do the blood clot in magenta. This blood clot might form because, no, that's not magenta. The blood clot might form because maybe there's a plaque there. Maybe the plaque got ruptured. Either way, this blood clot is restricting the flow of blood. And we know that this blood clot, we can call this a thrombus. Or we could say that thrombosis has occurred over here. Either way, the blood flow is restricted, and the brain tissue that's further downstream is not going to get its oxygen, and it might die. It might experience infarction. And that's why ischemic strokes are also sometimes called cerebral infarctions. Cerebral infarctions. These are all very fancy words, but I think hopefully they're becoming a little bit more common in our vocabulary. They keep showing up over and over again. And I also want to be clear, most strokes are actually ischemic strokes. The numbers I looked up, they say 87%. 87% of strokes are ischemic. Now, the other type of way that you could have ischemia in one of these blood vessels, and it's completely analogous to what we saw in the heart when we had heart attacks, is you could have thrombosis, or you could also have an embolism. Whenever someone says thrombosis or thrombus or thrombi, they're talking about blood clots. Whenever someone talks about an embolus or emboli or embolism, they're talking about something moving through the blood that eventually blocks a blood vessel. So you can actually have a thromboembolism. You can actually have a blood clot that gets broken off. So you could actually, so let me ignore this for now, or let me paint over it a little bit so that this isn't the main cause of blockage. But you could actually have a blood clot that breaks off, becomes an embolus. It becomes an embolus. And since it's an embolus due to a blood clot, you call it thromboembolus. I always have trouble saying all of these words. And eventually, it blocks an artery right over here. So this right here is an embolism. 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 But either way, you're blocking the blood flow further down the brain. It could cause infarction. That brain tissue will die. And whatever that brain tissue did for mental function or whatever is going to make it very hard for this person who's experiencing the stroke to do those things. Now, it's not always noticeable. That's called a silent stroke, but damage is occurring. The person experiencing the stroke, and I'm not a doctor, so take all of this with a grain of salt. The person experiencing the stroke, it could be anywhere from, well, one, they might not even notice it, even though damage is occurring. They might have a headache, or it might be more severe. They might actually not be able to properly move a side of their body or a side of their face, or properly be able to speak. So it really depends on what part of the brain is being damaged. But in either of these situations, an ischemic stroke is caused by some type of restriction or blockage that causes things downstream to not get proper oxygen. And then, so you can imagine cells over here aren't going to get their oxygen, and that they might actually die. A hemorrhagic stroke, to hemorrhage literally means to bleed. It's literally just a fancy word for bleeding. And so in a hemorrhagic stroke, you have a situation where a blood vessel can actually break. Where you have a blood vessel, I'm trying to draw the same blood vessel, where it actually breaks. We'll talk more in the future of why a blood vessel might break, strongly related to high blood pressure and other risk factors. Don't want to get into that right now. But you could imagine if a blood vessel breaks, you have all this blood spewing into the brain in kind of an uncontrolled way. So let's say this little diagram I do here, that's that part of the brain. If you have a hemorrhagic stroke, you have all this blood that's flowing into the brain, and you can imagine all that uncontrolled blood will mess up that part of the brain. It'll cause those neurons and brain tissue to malfunction, and maybe even cause some of it to die. And it would also cause the blood flow further downstream to be impaired. So it'll also, the stuff downstream aren't going to get the blood they need because all of the blood is being released everywhere else. And since 87% of strokes are ischemic strokes, the remainder are hemorrhagic. So this is the remaining, I should say, the remaining 13% of strokes.
Medical interventions for CVAs. So we diagnose a CVA with the use of a CT or MRI, and that will identify the area of occlusion. Um, Initial CT scans don't always show small lesions, and so that's when they will do an MRI. But as a lesion progresses, um, they can be seen more visibly on the CT. MRI diagnosis usually can happen within 2 to 6 hours. Takes a little bit longer for CT on small infarcts, but the point is they do that to determine whether it's an ischemic infarct or a hemorrhagic infarct because the intervention is going to be different at that point. And they will also do an evaluation of motor, sensory, speech, and reflex function to assess neurologic function. The main goal of acute medical management is to prevent secondary complications, and so that's important to be mindful of when looking at, well, why didn't they do more as far as physical therapy in the acute care setting? They will typically try to get stroke patients up and moving for PT as much as possible, but most of that doesn't happen until they get to the inpatient rehab setting or a SNF setting if they're not lucky enough to get into inpatient rehab. So, acute medical management will focus on regulation of the patient's blood pressure, their cerebral perfusion, and ICP, or intracranial pressure. Pharmacologic interventions to manage hypertension, including diuretics, beta blockers, and angiotensin converting enzyme inhibitors, or our ACE inhibitors. And so, it's important to know that in a patient following a CVA, the type of CVA is going to influence the target blood pressure range. And so somebody who's had an ischemic infarct, they might be trying to push for a little bit higher blood pressure than they would normally want in order to promote cerebral perfusion. But somebody with a hemorrhagic CVA, they definitely don't want an elevated blood pressure. And so that's not always going to be the case for your ischemic CVAs. And that's where you want to communicate with your medical team to find out what's going on there and make sure you're monitoring your vitals appropriately. Ischemic strokes can be managed with TPA if administered within 4.5 hours of the onset. So if it's an ischemic stroke, then they can determine that from the CT or MRI, and they know the time since last normal, and that time has been within 4.5 hours. It is safe to administer TPA to break up the clot. If it is outside of that 4.5 hour window, the risk of hemorrhage increases, and so it becomes unsafe to administer. And so when we look at asking patients about the history, knowing the time since last normal or the time that the patient demonstrated normal neurologic presentation, it's important for communicating to the medical team so they know what types of acute interventions they can take.
After you start to recognize that someone might be having a stroke, right? Maybe they have some of the symptoms we know to be common stroke symptoms, like maybe one side of their face starts to droop, or maybe all of a sudden they have some vision loss or some numbness or weakness on one side of their body. Then you want to make sure that this person gets to the hospital as quickly as possible. Because remember, more than any organ in the body, our brains love oxygen. Brain tissue cannot live without it, even for a few minutes. So in a stroke, when blood stops flowing to a part of the brain and thus deprives the brain of the oxygen it carries, the brain tissue that's missing out on oxygen starts to die off. So super important that whoever you're suspecting of having a stroke is taken to the hospital as quick as possible to save as much brain as possible. So now that we're at the hospital, what goes on there? What's going to happen? Well, a few things are going to happen. So, the plan is to diagnose the stroke, right, with some tests and some imaging, and then to treat the stroke with some medications. So let's take a look. So we know that part of diagnosis includes a physical exam to look for any physical signs that the person has had a stroke. Really importantly, it also includes imaging like CT and MRI scans. And it includes lab tests, blood work to look for an underlying cause of the stroke or to rule out other diagnoses like hypoglycemia, which can look like a stroke. So the kind of treatment that the person gets really depends on the type of stroke that they had. So let me show you what I mean here. You could have had an ischemic stroke, for example, where a clot blocks off a bit of blood vessel in the brain and causes a stroke that way. Or you could have had a hemorrhagic stroke, for example, where a weakened blood vessel in the brain starts to leak, maybe because of a ruptured aneurysm or some trauma to the head, like from a fall or something unpleasant like that. But how does the type of stroke you have influence treatment? Well, because for ischemic strokes, which you can usually identify on imaging, actually, let me clarify that. You won't be able to see any brain changes on CT scan right after a patient's had an ischemic stroke. That's why the CT up here looks pretty normal. But the key is that it doesn't look like a hemorrhagic stroke CT scan, which I'll show you in a few minutes. So the patient in whom you're suspecting an ischemic stroke gets certain medications that you definitely do not get in hemorrhagic stroke. So let me show you what I mean here. And let me bring up a blood vessel here to just show you how these medications work. So if the patient had an ischemic stroke and came to the hospital quickly enough, they'd often be given two types of medication. So one is aspirin, and aspirin doesn't actually do anything about the existing clot. It can't break it up or anything like that, but what it can do is prevent new clots from forming. So it stops platelets in your blood from working properly, because platelets in your blood are responsible for forming the initial component of a blood clot. So it stops those from forming. And really importantly, you might be given a type of medication called a thrombolytic. And this thrombolytic is the one that can potentially break up that clot that's causing the stroke, right? So you might have heard of clot busting medication, and this would be a type of that. So thrombo means clot, and lytic means to break something up. And this one in particular is called tissue plasminogen activator, or TPA. And that sounds like a pretty confusing name, but it's called tissue plasminogen activator because of what it does. It activates a compound called plasminogen that's already naturally found floating around in your blood as part of the body's natural mechanism to break up any clots that shouldn't be hanging around. So TPA sort of kickstarts this natural system already in your bloodstream to try to bust up the clot that causes a stroke, right? And actually when plasminogen gets activated by TPA, it turns into this compound called plasmin, and that's what's actually doing the busting up, the clot busting. That's why I wrote plasmin here. And really importantly about this drug, the benefit of TPA is the highest right after the stroke has occurred, and then it just kind of gets less and less effective from there. So again, I'm just trying to highlight the fact that the earlier the patient gets to the hospital, the better the outcome, the better the TPA will work. So that's ischemic strokes. That's sort of acute management of an ischemic stroke. With hemorrhagic strokes, though, it's a different story, because when you have vessels that are bleeding out, the first thing you want is for it to clot off and stop bleeding, and therefore the last thing you want is to activate your plasminogen clot busting system. So you won't be given TPA, because if you are given TPA, then your blood will be far less likely to clot, right? As we saw earlier, and blood will just continue to pour out of this deficiency in the blood vessel here, see? And actually, let me bring up a CT scan of a hemorrhagic stroke. Remember, I said I was going to bring one up. So you can see all of this blood here. This bright spot is a big collection of blood that's been sort of leaking out of blood vessels in the brain that have ruptured. And so you can see that this looks really different from the CT scan over here on the left of an ischemic stroke. And so this is why brain scanning is super important when you're diagnosing a stroke, because it really has big implications on how you treat the stroke afterward. So for hemorrhagic strokes, the focus of initial treatment has to be a little different than with ischemic strokes. So for example, with hemorrhagic strokes, it's really important to find out which blood vessel is bleeding. So where exactly in the brain the bleed is. And that can be done by the imaging tests like CT or MRI or angiography that we talked about. Because the goal is to stop the bleed, so it's important to first know where it is. And another thing, anytime you're bleeding from a vessel, right, losing blood, your heart starts to get a little worried, right? Good old heart, always looking out for you. So it starts to pump blood out a little harder, and it's thinking that that's what it'll take to get blood going everywhere again. So now your blood pressure has gone up. But there's two main drawbacks to that. One is that if a little clot has started to form, right, to seal up the initial tear in the blood vessel, if that new, maybe not so stable clot gets hit with blood racing along at high pressure, it might get dislodged and re-bleeding might happen. The second drawback to blood pressure that gets too high is, well, let's say that a clot hasn't formed and the bleed is still bleeding, it's still active. Then now blood will just start coming out of the vessel even faster, right? And that's probably the last thing that we want. So the patient might be given antihypertensives or blood pressure lowering drugs to try to keep the blood pressure from getting too high. It's also really important with hemorrhagic strokes that the healthcare team stops or reverses the effects of any medication that the patient's regularly taking that might increase bleeding, such as warfarin or the aspirin that we mentioned earlier. Also really important is that pressure building up in the brain and the skull from all this blood is controlled. And for starters, one simple way to do that is to just make sure that the head of the patient's bed is elevated. And this works just because of good old gravity. When the patient's head is elevated, then more blood will flow out of the head in the jugular veins, right? So that's one way of lowering pressure in the head a bit. And one reason why keeping pressure in the head at a normal-ish level is really important is that when your brain starts to get pushed on or compressed, it kind of disrupts the normal electrical activity in the brain, and you could end up having a seizure. So the doctors might consider giving an anticonvulsant, which is a medication to prevent seizures from happening. And another reason is just because some pretty vital areas in your brain, particularly your brainstem, they might get compressed with all of this pressure building up, and that's pretty quickly fatal. So we don't want that. And there are some other surgical ways to keep pressure under control, but we won't focus on that right now. But you can definitely start to see that management of hemorrhagic stroke is really about managing the patient until interventions like surgery can happen. Whereas with ischemic strokes, while you might still need more invasive treatment down the line, at least you can give TPA initially to try to get things resolved beforehand, try to bust up that clot before you need sort of more invasive treatment. So that's a quick look at some of the immediate management of ischemic and hemorrhagic strokes.
Recovery from a stroke is all thanks to neuroplasticity, and the most significant recovery in neurologic function occurs within the first 3 to 6 months after injury, but we can continue to see functional gains up to 5 years as long as continued intervention is implemented in CVA patients. Discharge planning should begin on initial evaluation with these patients because we need to know what their functional needs are at home, and we need to start preparing them both with our interventions and our adaptations that we provide them. Education in regards to prevention of CVAs includes that the risk of stroke doubles every 10 years after the age of 55, and so just by product of aging, you're at increased risk of a CVA. Medical risk factors include previous stroke, history of TIAs, cardiac disease, diabetes, AFib, and hypertension. Lifestyle risk factors include smoking, obesity, alcohol and drug use, and inactivity. Early recognition is important, so the FAST acronym has been developed to increase social awareness, and that stands for FACE. So we're looking for asymmetrical face presentation. Arms, if they can raise their arms up overhead, do they raise symmetrically? Speech, looking for speech that is confused or slurred, and time since last known normal. The main presentation of a CVA is going to depend on where the infarct occurred, and the area of the brain that was most impacted by the infarct is going to delegate what type of presentation we see in the patient. So when we look at anterior cerebral artery occlusion, this is looking at the areas of the brain that are supplied by the anterior cerebral artery, and so you can go back and review the chapter on the neuroanatomy. I think that's chapter 3 from this textbook. But if you would like to look at those to connect those dots, you can look at that vascularization. But these CVAs are uncommon. It supplies the superior border of the frontal and parietal lobes, and these patients present with contralateral weakness and sensory loss, primarily in the lower extremity, aphasia, incontinence, and apraxia. And apraxia is difficulty performing purposeful movements, remembering the steps or sequences necessary to complete a movement transition, or difficulty of remembering what to do with a certain item. And so we're looking at contralateral weakness and sensory loss because it's the opposite side of the brain controlling the opposite side of the body. And just based on brain area distribution, we're going to see the lower extremities more affected and the impacts of potential aphasia because of the speech areas involved. Middle cerebral artery occlusions are going to be our most common CVA type, and so that's going to be our most common patient presentation. These patients present with contralateral sensory loss and weakness in the face and upper extremities. It's not to say that the lower extremities aren't involved, but the upper extremity tends to be more involved than the lower extremity. When the dominant hemisphere is involved, it can lead to global aphasia. And these patients may present with homonymous hemianopsia or loss of conjugate eye gaze. So homonymous hemianopsia is loss of half of the visual field from each eye. So it's not that they lose vision from their right eye, it's that the right half of their visual field in each eye has lost vision, or the left half of their visual field in each eye has lost vision. And so that can lead to things like neglect, where they don't notice half of their world. And conjugate eye gaze is the ability to focus on things. Vertebrobasilar artery occlusions are going to happen at the base of that posterior circulation, and so they're going to typically involve the brainstem bilaterally. And these CVAs are often fatal. We don't tend to see a lot of patients clinically with vertebrobasilar CVAs because of the fatality rate. The cranial nerve involvement when we do see these patients, they can present with cranial nerve involvement if the brainstem has been spared of the life management functions that it needs to maintain. And so they'll present with diplopia, dysphagia, dysarthria, deafness, and vertigo. And they may present with ataxia because of how close in proximity the cerebellum lies to this blood flow as well. Basilar artery involvement can result in locked-in syndrome. And so that's patients who have no motor control except of eye movements. They have conscious awareness. They don't typically have a whole lot of sensory perception, but they have conscious awareness of their environment, but they can't communicate anything. They can't move anything other than their eyes. And so a lot of these patients can go undiagnosed and as in a vegetative state. So again, we don't see these patients as commonly clinically because the likelihood of survival is very low, and the ability to regain function after one of these is also really low. Posterior artery occlusion, so this is after that vertebrobasilar where it's now branched off to the posterior branches of that circle of Willis. These patients can present with abnormal perception of pain, temperature, touch, and proprioception. They present with contralateral sensory loss, pain, memory deficits, homonymous hemianopsia, visual agnosia, and cortical blindness. Lacunar infarcts occur deep in the brain, and so they are small vessel infarcts, and so there's typically multiple lacunar infarcts that occur in lacunar syndromes. These are more common in patients with diabetes and hypertension because of it being related to the small vessels. And these patients present with contralateral weakness and sensory loss, ataxia, and dysarthria. Other stroke syndromes to be familiar with would be a stroke occurring in the parietal lobe can cause inattention or neglect, and impaired perception of vertical, visual, spatial, and topographic relationships and motor perseveration. Thalamic pain syndrome can result as a result of an infarct to the thalamus, and the patient experiences intolerable burning pain and sensory perseveration. And pusher syndrome is when the patients actively push and lean towards their hemiplegic side, and they are at an increased risk for balance deficits and falls. And this is related to them having a poor orientation or perception of midline and upright. And they frequently report sitting or standing upright when in fact they're actually tilted approximately 18 to 20 degrees towards their hemiparetic side, but they're perceiving that they're at an upright position. With these patients, we want to avoid fixed resistance on the affected side. We don't want to push back against their pushing because this typically results in them pushing harder, and it increases those pusher tendencies, which then can put them at greater risk of fall because they're pushing towards their weak side. Motor impairments of CVAs. So spasticity we talked about is velocity dependent, which means that we have to have speed to the movement in order to produce spasticity. And it typically onsets in a CVA after initial flaccidity and is graded using the modified Ashworth scale. And so to test spasticity, we would grasp a patient at their joint lines to move the extremity so that we are taking the muscle into a lengthened position. And then we score the response based on the modified Ashworth scale, which you can find on page 353 on table 11.2 in your textbook. This can be treated with oral medications such as baclofen, Xanaflex, and Dantrium. Spasticity in proximal muscle groups initially develops in the muscles of the shoulder and pelvic girdles, so we get adduction and downward rotation of the scapula. Anterior tilting or hiking of the pelvis is common. Upper extremity tone increases to typically include the biceps, the forearm pronators, and the wrist and finger flexors. And that's that CVA position. If you think about tensing your biceps, your forearm pronators, your wrist and finger flexors, you're going to get the arm upright at your shoulder level, cocked in, not really a functional position. And that's a very common position for patients following a CVA. I think you guys can visualize that. And lower extremity tone increases to typically include hip adductors and internal rotators, knee extensors, and ankle plantar flexors and supinators. And this again is a common presentation in patients following a CVA. However, it's less common to be able to visually identify because we more typically see middle cerebral artery involvement. That's the most common CVA type, and so that's what we're going to see more clinically. And that affects the upper extremities more than the lower extremities. We will also see motor planning deficits in patients following a CVA, most frequently noted in patients with involvement of the left hemisphere. And these patients present with apraxia, which is difficulty in performing purposeful movements, although no sensory or motor impairments are noted. So it's just a matter of planning that they can't execute. We can score a patient's level of flaccidity or spasticity or level of motor tone using the Brunstrom stages of motor recovery. Clinically, I don't really know how widespread these are still used, but for the licensure exam, it's important that you familiarize yourself with these stages. And they describe the characteristic stages of motor recovery following a stroke. And a patient will typically progress through each one of these stages. Each patient is going to vary in how fast they will progress through each stage, and patients don't typically skip stages, they go through them sequentially. And so it starts with that initial onset of flaccidity for stage 1, and then spasticity onsets for stage 2, and it peaks in stage 3, and then goes from there, decreasing in intensity of spasticity until we get resolution of normal function or normal muscle function for stage 7. And so this looks at muscle synergies, and a synergy is defined as a group of muscles that work together to provide patterns of movement. They initially occur in flexion and extension combinations. And so these are where we have the inability to dissociate limb segments. And so flexing the shoulder causes flexion of the elbow and flexion of the wrist. Things happen simultaneously instead of being able to dissociate each limb segment and move for the intended execution. These motions are stereotypical and primitive, but they are the initial return of motor function that we typically see in patients following a CVA. We talked about how a patient passes through all the stages and the stages are not skipped. However, variability in a patient's presentation at any stage is possible, and it's helpful in the recognition of hemiplegic movement patterns and motor recovery in our patients. Determining their Brunstrom stage can help us determine the appropriate interventions to utilize. This one is not going to play, so go watch it on your own. Other impairments in patients following a CVA can include sensory impairment, which are going to be most common in patients with parietal lobe involvement because of the somatosensory cortex. Patients tend to have partial impairments as opposed to a total loss of sensory integrity, and that's because of how the neurons intermix as they travel through the sensory motor tracts. They may also affect the patient's ability to control and coordinate movement because remember, we need some kind of sensory feedback to control and coordinate our movement and make sure that we are giving the right motor output for whatever our demand is. Communication impairments are also possible. Frontal and temporal lobes are most commonly affected when we see communication impairments. So we can see expressive aphasia, also known as Broca's aphasia, and that is the inability to express speech. And individuals frequently become frustrated when they are unable to articulate their wants and needs. This is more common with frontal lobe involvement because of the motor area for speech that is involved in there. Receptive or Wernicke's aphasia can be challenging because you won't be able to rely on verbal instructions to direct activity performance, and this means that the patient can't understand what you are communicating to them. So they can hear your words, but they can't make sense of the words that you are saying. Expressive aphasia can be the inability to articulate words, but more commonly it's the inability to articulate sensible or sensical words. And so when we see both of these present, both expressive and receptive, we would deem that as global aphasia. Time and patience are needed so that the patient will begin to trust the therapist and for the therapeutic relationship to develop. We can use things like communication boards to help give the patient an outlet to be able to reliably communicate, but them being able to trust that you're going to take time to understand what they are trying to say is one of the biggest barriers that you need to overcome in building that rapport with your patient. Patients can also present with dysarthria, which has to do with the ability to control the motor function of the mouth and articulate speech. So dysarthria is going to be that slurred or gargled speech that can occur following a CVA. And emotional lability can be common where we see fluctuations in emotion, where they can be extremely happy followed by extremely sad, or we can see normal level of emotions, but things when they affect them, they just affect them to a severe extent, and they can become very weepy in a clinical presentation. These patients may cry with a very easy onset. They can communicate that they feel fine, but they still are overcome with emotions, and this is common in right hemispheric infarcts. As a team, we'll work closely with the speech therapist to help the patient with those communication deficits and making sure that we are building on strategies that work together. We'll also work with speech therapy in regards to orofacial deficits that can be present. And these are often associated with cranial nerve involvement, which can occur with strokes of the brainstem or the midbrain region. The use of facial expression affects the ability or the person's ability to use body language as an adjunct to communication. And so this can influence the person's mood or behavior if they feel like their body language isn't matching what they're verbally trying to communicate. And if their facial expressions, they can tell they're not getting what they want out of it. This can create a psychological barrier for patients. Inability to control facial muscles can also cause problems with control of saliva and fluids, which can cause choking risks or just drooling risks. These patients can have ptosis, which is a drooping eyelid. They can be unable to close their eyes for lubrication, and they can experience dry eyes. They can suffer from aspiration, like we talked about, that choking risk, and dysphagia. Respiratory impairments include that lung expansion may be decreased because they have decreased innervation of the respiratory muscles to ventilate the lungs. The patient is forced to increase the respiration rate to get the same volume of air flowing through. This puts them at risk for pneumonia and atelectasis. They have a decreased tolerance to exercise and a decrease in peak aerobic performance of 50% compared with the general public. And participation in exercise and functional activities will improve the patient's tolerance for activity, and a certain level of intensity is needed to induce neuroplasticity and functional recovery. So despite the low respiratory tolerance, we still need to push our patients to a certain aerobic level in order to induce the neuroplasticity needed for stroke recovery. Following a CVA, patients can demonstrate reemergence of those primitive reflexes that are supposed to integrate during childhood that we talked about during the pediatric unit. And when we see those reflexes, it doesn't say that the patient is actively moving or moving on their own. It's just a reflex, and so we can't attribute that to improved motor function. So you can look at table 11.5, 11.6, and 11.7 on page 357 of your textbook to familiarize yourselves of the most common ones that reemerge following a CVA. But we look at the spinal reflexes, or listed on here as deep tendon reflexes, and flaccidity may cause hyporeflexia, spasticity may cause hyperreflexia, and clonus is the alternating periods of muscle contractions and relaxations. I think we've looked at the video of that as a result of DTR provocation. We're going to see clonus more commonly in our spinal cord injury patients, and so I believe we've got a video coming up of that in that unit, but just know that it can be present in our CVA patients. Brainstem reflexes, primitive reflexes that alter the posture or position of a part of the body. And so that can be like our ATNRs or our STNRs that we talked about in the pediatric unit. And our associated reactions are automatic movements that occur as a result of active or resistive movement in another part of the body. And the reemergence of primitive reflexes such as ATNR or Babinski can happen following a CVA, and that's important to remember. It does not demonstrate normal motor movement, though, and so we have to figure out how to get the body to reintegrate them. We can also see bowel and bladder dysfunction. Early weight bearing can assist the patient with regaining bladder control. Movement and activity assist with the regulation of bowel function, so therapy plays a huge role in helping a patient regain bowel and bladder function. And we also can help be a part of the bladder retraining program where we get a patient on a schedule for using the bathroom in order to retrain their bladder to empty at regular intervals, and then they can start working on control from there. And functional limitations that can be seen. Great emphasis during treatment is placed on function and an individual's ability to participate in life roles. Treatment goals and intervention plans must be functionally relevant and meaningful to the patient. We should always be considering function with our neurologic patient population, really with any patient population, but I think that there's a special place for function with the neurologic population. Following a CVA, we see abnormal motor control, and this can result in abnormal positioning and posturing, which can cause contractures and deformities. Most commonly, we see flexion contractures of the elbow, wrist, and finger flexors, and plantar flexion contractions of the involved ankle. The abnormal motor control and increased tone that typically causes these can be managed with medication, but that medication decreases central nervous system activity and promotes lethargy, which can make it difficult to work with patients, especially for therapy sessions. Extensor tone in the lower extremities may allow a patient to weight bear on the involved lower extremity and may provide some lower extremity stability during ambulation. So sometimes we can use a patient's tone to our advantage until we're able to get it normalized. And it's important to note that while increased tone through the elbow, wrist, fingers, and lower extremity is common, there's typically decreased tone through the shoulder. And so shoulder subluxation is a common complication following a CVA. And a lot of these patients will be placed in a subluxation sling to help support the glenohumeral head in the socket, so that way we don't experience that subluxation, especially as we try to regain movement of the upper extremity. So it's really important to pay attention to that, especially when we're helping patients with functional tasks like bed mobility, that we don't pull on the involved extremity because of that increased risk of subluxation. And another complication is complex regional pain syndrome. I believe you guys spoke about this with Ms. Scott and Therex. But prevention through proper positioning and handling is important, and patient education and active functional use of involved extremities, elevation and compression of involved extremities, and weight bearing through involved extremities are all important components in preventing CRPS. Early physical therapy intervention is going to include cardiopulmonary retraining. Again, we've got decreased depth of respiration, so an increased respiration rate, and we've got to retrain the cardiopulmonary system to be able to work efficiently. This can include doing things like diaphragmatic strengthening so that we improve respiratory muscle function. We want to encourage different positions following a CVA, especially in an effort to prevent that abnormal positioning and contracture development. So when we have them in supine, we want to make sure the scapula are protracted using towel rolls in between the shoulder blades. The involved upper extremity should be externally rotated, abducted 30 degrees, extended elbow with the forearm supinated, and supported by pillows, so that way it's kept out of the position of tone. And the bilateral hips and knees should be flexed with bilateral ankles dorsiflexed to, again, help break up the tone. I know hip flexion is a position of tone for the lower extremities, but placing them into hip flexion with knee flexion and dorsiflexion helps to break up that tone and reduce its onset. For the side lying position, we want scapular protraction with elbow extension and a neutral forearm. The hips and knees should be flexed with ankle dorsiflexion when lying on the uninvolved side. But when we have them on the involved side, we want the hip extended with the knee flexed. This again is just to help break up the tone. When we are lying on that side, we have more weight bearing through the extremity, and that helps to decrease the abnormal motor function. And so placing them into hip extension with a knee flexed helps to combat the normal tone presence and move the joints into the opposite direction. Minimizing abnormal tone and neglect. Positioning and side lying on the involved side decreases the effects of spasticity and decreases the effects of neglect. And so that can promote involvement of motor functions and motor perceptions connected to visual scanning. When we are promoting visual scanning in an upright position, we want to place stimuli on the involved side, and this includes when we are leaving patients in a room. We don't want to position them with the TV set up on the side where they're constantly paying attention to. We want to put it on their side of neglect to encourage them to move to that side. We want to educate family to visit with the patient on the side of neglect to encourage acknowledgement of that side. And we always want to leave items within reach, remembering the functional limitations of our patient and their neglect. Our early functional mobility tasks are typically going to be initiated in bed, and we want to start with hips and shoulders because we need proximal stability to develop distal stability. And so for engaging lower extremity function and preparing for things like transfers and even bed mobility and gait, we can start with bridging and bridging with approximation. So pushing pressure down through the knees to approximate the hips and get that facilitation of muscle activation. When we're having a patient perform these activities, we want to do a movement assessment, looking at the timing of their movement, the sequencing of their movement, their force production, and their reciprocal release or eccentric control, and seeing which area they have the biggest area breakdown in and trying to target our intervention and our cues towards where that breakdown happens. Scapular mobilizations can be performed to provide range of motion and mobility to the scapula, which can be held in that abnormal retracted position that then doesn't provide the support needed for the glenohumeral head and puts them at an increased risk of shoulder subluxation. We can perform facilitation techniques to get muscles that aren't firing to fire, and that can include things like performing a quick stretch to the muscle before getting it to activate. We can provide that tapping over the muscle for that tactile stimulation. We can provide vibration to the muscle, and we want to do that going from the insertion of the muscle to the origin of the muscle. So we start distally, move proximally when we are applying vibration techniques for facilitation. We can use the approximation while we compress the joint to facilitate that muscle activation, and weight bearing is a form of approximation, and so any weight bearing activities are always appropriate for facilitating muscle activation. On the other end of that spectrum, patients also need inhibition techniques for muscles that are activated at a time that they're not supposed to be. And so we can utilize things like upper and lower extremity splints to inhibit muscle activation. Remember, we've talked about rhythmic rotation being an important component to minimizing spasticity, and so whether that's applying to the trunk or to a specific extremity as needed, rhythmic rotation is an inhibition technique. And then weight bearing, while it's a facilitation technique for muscles that aren't activated, it's also an inhibition technique for muscles that are overactivated because it tries to find that balance needed. Early intervention techniques can also include utilization of the neurodevelopmental treatment approach, or NDT, which emphasizes the management of abnormal muscle tone and the importance of postural control in movement initiation. And the goal of NDT is really to get rid of abnormal postural reflexes and abnormal tone, and then superimpose normal movement patterns on top of that. NDT utilizes the developmental sequence a lot of through the prone progression to achieve those normalizations of muscle tone, and the therapist controls and guides the patient's motor performance, transitioning through this developmental sequence as appropriate to the patient's level, using manual contacts that are applied at proximal joints to facilitate while the patient completes the functional movement. Our primary goal following a CVA is the restoration of function, and so we're going to focus our treatment on functional activities depending on the level of the patient, and we are going to treat at the level of the patient. So if they are max assist for bed mobility, we're going to start by focusing on teaching them how to roll. So for rolling, we always want to initiate movement by having the patient look in the direction they are rolling towards. We want to practice rolling towards the involved side and rolling towards the uninvolved side. Rolling towards the involved side tends to be easier because they've got the uninvolved side that they can use the arm to pull with, and they can push with the upper or the lower extremity. Rolling to the uninvolved side, we got to teach them to clasp their hands so that the involved thumb is the outermost to help initiate that movement, and get them in hook lying instead of having that one leg straight, because we need the involved or the uninvolved side to assist in the motion. Techniques such as slow reversals and hold, relax, active, or PNF techniques, can be incorporated into rolling activities to help assist with appropriate muscle facilitation and inhibition as needed. Following rolling or building on to rolling, we'll need to work on scooting, teaching the patient to flex the head and neck as they work on scooting, to assist with transitional movements following that. These things will typically happen in hook lying, and bridging can be a part of scooting, where we need to work on bridging before we can scoot so that we make sure we reduce any shearing movements that happen. Working on movement transitions, we've got supine to sit. We want to make sure we practice the both sides. We are going to educate our patients to transition towards their strong side in most cases because of safety, right? But we want to teach them how to do both because it's not practical to think that you can always go towards one side. Be careful to avoid distractional forces when providing assistance with a patient, especially from supine to sit. Remember the risk of shoulder subluxation, but really just not wanting to pull on their extremities as you are assisting in that process. These movements can be performed in a straight plane or diagonal movement pattern. So again, implementing our PNF techniques to help facilitate muscle activation, muscle strengthening, and encourage the right motions that we need. We'll also work on wheelchair to bed transfers, starting towards the strong side, but needing to practice both. Again, this is what we've talked about. But there are also some exceptions, like patients with pusher syndrome. I'm typically going to set that patient up to transfer towards their involved side because their natural inclination is already to push towards that direction. And so there are some limited exceptions with that, but we're going to start towards the strong side in 99% of the cases. But again, we need to practice both. Performing transfers requires weight shifting and scooting. So if we haven't mastered scooting, or if we've mastered scooting in supine, but we haven't mastered scooting in a seated position, we may need to back up and practice those things before we perform the transfer. And we always want to make sure we block the involved knee as needed, because if they do not have sufficient quad control, we cannot expect the quad to maintain that control and hold them in a standing position. And so we want to make sure we have the knee blocked as a precautionary measure. When we are performing any of our functional activities, be careful not to over-assist your patient. You are training them. You don't want to do the things for them. It's not a matter of trying to get them done. It's a matter of teaching the patient how to achieve them, strengthening appropriately. So find the area of breakdown and work there first. Overall, an initial treatment plan may look something like this, but really the important thing is individualizing your treatment plan towards your patient. What are their biggest functional deficits and what are their biggest functional needs? Because your functional needs are not the same as your patient's functional needs. And so you have to communicate with your patient, identify what they need, and then what impairments are limiting them from getting to that, and address those impairments starting with where they are. Functional implementation is so important in neuro populations because it helps with the retraining and the neuroplasticity if we do the things we need to train them to do. And if we take patients through the developmental sequence to help promote that neuroplasticity, we've got an even better layer. Since we need to meet our patients where they're at, maybe they've exceeded the level of needing to work on bed mobility. That's probably not the case overall. We probably still need to work on those mat bed related functional activities on some level because, again, building the proximal stability is going to help us for the higher level tasks. But we want to challenge our patients sufficiently too, so we're going to take a look at some other functional positions as well. So seated activities, we can focus on motor control, just trunk balance, dynamic trunk control. We want to make sure that we're looking at how the patient is positioning their pelvis. Remember that they will typically fall into an anterior pelvic tilt, and so can they maintain a neutral pelvis in the, their tone will cause them to fall into an anterior pelvic tilt, but then when they come into a seated position, they will go into a sacral sitting because of the lack of trunk control. And so we want to encourage our patient to actively engage in anterior pelvic tilt without causing spasticity. And so we may need to work on how much we can engage that, what range we can work through, and build from there. Positioning the trunk is important. Again, we want to make sure that we can encourage a neutral spine throughout the sitting position. So we want to encourage extension of the trunk, getting that upright posture and promoting midline, especially in our patients with pusher syndrome. Positioning of the head, again, we want to have a neutral spine. So position the head with that upright posture, trying not to get the forward head that most of the patients, especially following a CVA without normal muscle tone, are going to achieve. Weight bearing on the involved hand, having them do weight shifts side to side with hands on the mat table. Shoulder subluxations are going to be assisted by the performance of weight-bearing activities. We can also use functional electrical stimulation and biofeedback in slings like we talked about. to help support the shoulder for functional movements. But having the patient weight bear through that upper extremity is going to promote the shoulder muscle activation that we need to prevent the shoulder subluxation. We also can work on weight shifting patterns. So the trunk should be elongated on the weight bearing side to maintain an upright head. So teaching them how to maintain orientation to midline. And again, those equilibrium reactions and righting reactions that we talked about in the pediatric unit, those come into play following a CVA as well. Alternating isometrics and rhythmic stabilization can be used as stability improves, focusing on the trunk. We want to assess the protective reactions, and so that can include applying perturbations to our patient and seeing what kind of responses they engage. Do they get the upper extremity involvement that we need when pushed to the side that's involved? And we also can work on trunk rotation and sitting. Using bilateral PNF patterns like our chops and lifts can be used, but we can also perform functional reaching activities or even just having them do rotation seated. If we look at a prone progression or the developmental sequence through the prone progression, sitting isn't really on that. And so we talk about sitting activities a little bit separately. And I think that we're going to talk about standing activities a little bit separately as well. But the concept of the developmental sequence is that you can apply the same activities to any of these positions. So weight bearing through extremities, working on weight shifts, working on reaching with weight bearing through whichever extremities, challenging the dynamic balance through all of these positions. So starting in prone, then working to prone on elbows, building into quadruped, then performing quadruped activities, then working your transition from quadruped to tall kneeling, being able to perform activities in tall kneeling, then transitioning from tall kneeling to half kneeling, then being able to perform activities in half kneeling, and being able to perform a transition from half kneeling to standing, or a modified plantigrade position in which they have some upper extremity support, but that transition and those standing activities, or modified plantigrade, which is standing with a slight anterior lean due to upper extremity support. So if we look at our standing positions, once we've gotten through that developmental sequence and we get our patient up into standing and they're safe to perform these things, where do we want to be? Well, relative to the patient, we want to allow the patient enough space to move while providing them the appropriate level of safety. So we're typically going to guard on the involved side or in front of the patient. One of our maybe exceptions is patients with pusher syndrome, but you're always going to err on the side of caution. Don't push back into the patient if you are guarding on the involved side, because that will increase their pusher tendency, but see what works for that patient specifically. Performance of sit to stands are typically difficult early on, and the patient will assume a crouch position and then kind of stand up from there. Anterior weight shifts are a deficit, especially if they have poor midline orientation. A lot of patients following CVA will have a posterior lean in a seated position, and so achieving the appropriate anterior weight shift that they need to get from seated to standing can be difficult. We want to make sure that we ensure symmetrical use of all involved extremities, so set them up with armrests or blocks to push up from and get that weight bearing through the upper extremities when going in our transitions from sit to stand. And monitor the involved upper extremity and protect it as appropriate, especially if the patient is demonstrating shoulder subluxation. We have to establish knee control in standing. That is probably our most important thing to establish before we can initiate gait, because if we don't have adequate knee control, then we can't have safe ambulation. So patients are at risk for buckling and or knee hyperextension during stance. Knees will buckle when they don't have appropriate quad activation, and they will also go into hyperextension in an effort to lock into place when they don't have appropriate quad activation. And so that's one of the areas of emphasis that we need to focus on. So terminal knee extensions can be a good one for a patient following a CVA, whether that's with a ball behind their knee where they push in so that we can block them against that hyperextension and keep the knee protected, or with a band in around their knee pulling forward, whatever works more appropriately for the patient. Positioning and standing should ensure equal weight bearing and midline orientation. Again, in our patients with pusher syndrome, this is going to have a special importance, but trying to make sure that the patient can understand how to weight bear equally on both extremities, especially when they don't trust the involved lower extremity to accept weight, and how they can maintain balance with an equal distribution of weight. We may start the patient with a tilt table or a standing frame depending on the level of support that they need and their midline orientation and their tolerance to upright based on their blood pressure. Providing upper extremity weight-bearing support surfaces with help to promote an upright stance can be helpful. It increases the proprioceptive input to the upper extremities, it positions the upper extremities for protection, and it decreases the load on the lower extremities in standing. And so there is highly indicated reason to utilize upper extremity support in initiating standing activities with these patients. Weight shifting is important to ensure the appropriate position at all joints through the trunk and bilateral extremity during weight shifts, so that way when we transfer it over to gait, we know that we are going to have the appropriate alignment to avoid injury. We want to work both anterior, posterior weight shifts and lateral weight shifts and assess a patient's balance responses, promoting the proper activation of ankle strategies prior to hip strategies, prior to stepping strategies. Do they have the appropriate motor planning to respond correctly? What are their responses to small perturbations versus large perturbations, and how can we train those things? The goal of standing is to progress to walking, and so in regards to the therapist position, that's not really going to change from standing to walking. We're still going to stay in front of or on the involved side of the patient, depending on which promotes the best safety. We work on advancing the uninvolved lower extremity. This will involve weight bearing on the involved lower extremity, so that helps with the muscle activation that we need, and it kind of gives the motor sequencing needed because the brain has less of an issue planning what to do with the uninvolved extremity than it does with the involved extremity. The patient tends to want to take a short step secondary to feeling unstable standing on the involved lower extremity, and so one of our areas of focus is going to be promoting weight bearing on the involved lower extremity to achieve a proper step length. We might start with really small steps to get them confident in that single leg stance time, but we're going to work on promoting a normal step length with weight bearing on the involved lower extremity. Then we can work on advancing the involved lower extremity, and this can be difficult due to synergy patterns kicking in that make normal gait mechanic lower extremity movement difficult. So we have to pay attention to what Brunstrom category this patient is in, as well as how we can break up those muscle synergies and what training we need to implement. Positioning the pelvis is important. Again, proper gait mechanics are going to require the appropriate pelvic positioning. In a standing position, patients are going to tend to fall into an anterior pelvic tilt, and so we need to focus on training the posterior pelvic tilt appropriately, which is why it's important in the seated position we work both directions to prepare for standing. Before we go fully onto a gait sequence, we'll also work backwards stepping because we want to ensure stability in both directions in case there's a loss of balance during gait. Can they recover with a posterior step? Then we'll work on normal gait and short distances in a straight line pattern, then progress to the increased challenge of adding turns and turning around. And then upper extremity positioning during ambulation. We always want to protect the involved upper extremity and consider how it will be used during gait. So if a patient's using a rolling walker and they need both upper extremities on the walker, do they have sufficient grip to maintain that, or do we need to have a walker splint created for them to maintain correct upper extremity positioning? If we're having them use a hemi walker where they only need one side and the involved extremity just needs to be supported, is there an appropriate sling that they need to be in so that way we aren't at risk for subluxation? It's just making sure that we're paying attention to upper extremity positioning and whether or not we're using the upper extremity, and if we are using it, are we using it correctly? This slide just kind of sums up general basis of what we just talked about, where an outline for a training program for a patient following a CVA, once their knee control has been established, is you practice forward stepping with the uninvolved lower extremity, then forward stepping with the involved lower extremity, then backward stepping with the involved lower extremity. Then we practice putting several steps forward together where we start normal gait. This is just a recommendation and it's a good place to start, but understand that each patient will respond differently and your treatment approach should be individualized based on the patient response. Don't follow this like it is a recipe for a cake that you can't mess up. When we're doing ambulation training with patients following a CVA, we want to note what their functional capacity is, and so quality of movement versus function. There are a lot of things that may not be typical gait pattern that we can restore in a patient following a CVA, but it gives them the greatest amount of function. And it's our job as a therapist to balance that compensation versus adaptation line and help them find the best quality of movement that promotes safe joint alignment, safe movement, safe patient behavior, but also promotes the optimal level of function and highest level of independence. This can include the appropriate assistive device that we give them. And so, what assistive device we train them with, how we train them to use it, and what their functional demands are can factor into what the most appropriate assistive device is. I would say that these are listed in order of level of restriction. So a rolling walker is going to be more restrictive than a hemi walker, that's going to be more restrictive than a quad cane, that's going to be more restrictive than a single point cane, because they get a smaller footprint as you go down the list here. But that smaller footprint also means that they are less stable as you go down the list. And so that balance has to work for what the patient needs, what the patient can use, and what is safest for the patient. Ambulation training with assistive devices, we want to make sure that we initiate movement with the assistive device first so that we know that it is in the spot prepared for the patient to take the step and it is in the most stable position. So moving the assistive device first, training the patient to be aware of that and ensuring its stability to prepare for the patient to step is a very important attribute to ambulation training. And then once we have the patient stable on level surfaces, we have to consider that everywhere we walk in this world isn't stable, including the tile in the gym is much different than the carpet in their house that they're about to go home to. So once the patients achieve stability over a firm surface, dynamic challenges need to be added to address environmental demands. Common gait deviations in a patient following CVA can be found in table 11.9 on page 395. There are deviations due to issues with the hip, issues with the knee, and issues with the ankle. And so highlighting those, I'd say the most common gait deviation as a result of an issue at the hip is going to be hip circumduction. The most common gait deviation as a result of an issue at the knee is going to be knee hyperextension during gait, and the most common as an issue at the ankle is going to be foot drop. I would familiarize yourself with all of them in that chart, but these are going to be your most commonly seen clinically. It's important for us as therapists to identify the gait deviations so that we can address the underlying cause. But when we can't completely restore the underlying cause, then we want to consider the use of orthoses for ambulation. And the most common orthoses that we're going to see in patients following CVA are going to be our AFOs, our prefab AFOs, our custom AFOs, and our articulated AFOs. We will typically have a patient start with a prefab AFO, and if that doesn't cause any skin issues, then we don't have to worry about a custom AFO. But if we have skin breakdown, then a custom AFO becomes more appropriate. Articulated AFOs are dependent on the level of ankle control that they have and whether or not we need some kind of spring to get the dorsiflexion needed or what we're seeing in the patient's ankle control. A lot of times, knee control can be influenced by the use of an AFO because enhanced stability at the ankle improves the body's ability to control the knee. And so if we have a patient who either has buckling or more commonly hyperextension during stance at the knee, that can also be addressed with use of an AFO. So how do we determine if a patient is appropriate for an AFO to make a recommendation to our PT? Well, we can use an ACE wrap and wrap them into dorsiflexion and trial gait training with dorsiflexion ACE wrap and see how that goes and document it and then communicate that information to our supervising PT so they can be like, hey, all right, yeah, I'll make the call to the orthotist and have them come in and fit them for an AFO, or go ahead and try that prefab in the closet, and as long as there's no skin breakdown, we'll get one ordered for that patient. So remind me when we go over this lab and I will show you guys how to do an ankle dorsiflexion wrap. If the world were flat, we wouldn't need to know how to negotiate environmental barriers, but since it's not flat, we have things like elevations. And so following ambulation training, obviously we want to make sure that a patient is safe with gait before we try to initiate environmental barriers, but we may not be concerned with the distance of gait as much if a patient has steps to enter their home and their discharge goal is to get home. And so we've got to be able to get them to walk the 15 feet they need to get from one room of their house to their next before they can sit down, and they need to be able to do 3 steps, becomes more important than being able to walk 150 feet to be a community ambulator. So environmental goals are going to be patient specific. We're not going to stress stair negotiation for a patient who lives in a single story home with no steps to enter, who doesn't need to negotiate stairs to go home, in the same way that we are going to stress them for a patient who does have that obstacle to discharge. So when we look at stair negotiation, we want to train up with the good, down with the bad. So we're going to go up the stairs leading with the uninvolved extremity, so that way we have that extremity lifting. And when we go down the stairs, we want to lead with the involved extremity so that the uninvolved extremity is doing the eccentric controlling as we lower down the step. When negotiating stairs with a cane or quad cane or a hemi walker, we want to teach them to go up and then bring the cane with them when going up the steps. So cane last up and cane first down. So move the assisted device first when going down, but move the assisted device second when going up. And this is because of placement, stability, and handrail usage. And also wanting to practice curbs and ramps, same rules are going to apply as far as positioning of the assisted device and which extremity we want to lead with. However, when we are going up a curb, we are going to put our rolling walker up on the curb as we step up with the uninvolved extremity, and then going down a curb with a rolling walker, we're going to set the rolling walker down first and then step down with the involved extremity. Again, this is going to promote the highest level of safety. Practice stair negotiation and curb negotiation in class, so that way your instruction would be seamless with your patients. Functional mobility is going to be our primary emphasis of intervention during physical therapy following a CVA. No matter what stage on the continuum of care the patient is on, we are trying to help them maximize function. But in treating a patient as a whole, we can't just focus on function, because then we're doing a disservice to the other parts of the body that will contribute to other functions. And so other interventions that we will employ will include family participation with caregiver training, especially if the patient requires physical assistance. We're going to help them with fine motor skills, and this might be something that we work with OT with to help collaborate and ensure that the emphasis is placed in the right disciplines at the right time. We'll work on advanced lower extremity exercises to prepare for continued progression of function, coordination exercises for balance and safety and decreased fall risk, and all of the things necessary, again, that contribute to function but may not be just performance of the functional task. And then balance exercises to increase safety with all functional tasks, including dynamic balance activities, dual task training, which means including cognitive challenges while they perform whatever mobility task it may be, advanced balance exercises, and utilization of unstable surfaces like Swiss balls, Bosu balls, tilt boards, all of those things. Discharge planning should begin at initial evaluation. It should involve the family, it should involve the patient, and it should assess the home environment, whether that's performed by the therapist or performed by family communication, patient communication. We want to make sure that we know what the patient needs to be able to do to go home, so that we are appropriately implementing the interventions that will restore their function for safe discharge. Here is a little quiz time to see if you've been paying attention during this lecture. I am not going to read these to you, but I am going to scan through these questions. I do have the answers provided after each question, so that way you can check yourself as you go through this, but go ahead, read them, pause as you need if you need time to think before I click to the answer. I think there's like 5 or 6 questions here, but you'll see as you go through them. Answer in 3, 2. 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 Last question here. Answer in 3, 2.